I really and thank all the people from MicroAir for making this product that helps me do this. So without further ado, my disclosure is that I have received compensation as a consultant for MicroAir. And so first I want to explain what is lipedema. It's not well known. Most people do not, in the general population, even among medical providers, it's poorly known and recognized. But it's a progressive connective tissue disease that affects the subcutaneous adipose tissue in the extremities. It causes pain, swelling, and tenderness. And untreated, it can lead to mobility impairments, lymphatic impairments, and ultimately disability. So, so how do we diagnose it? How do we recognize lipedema? It has a patient history. It tends to, it occurs almost exclusively in women. Onset is generally around hormonal changes, and it causes the pain and swelling that I just discussed. And then we do a detailed physical exam, and then we rule out competing diagnoses, because there are other things that can cause swollen and tender legs. So this is a typical lipedema patient here on the right here, and the exam, we want to inspect for symmetry and proportion. So what I mean by out of proportion, or the proportion is the legs and arms are larger than the waist. So the waist is relatively small, but there's a lot of this subcutaneous adipose tissue collected on the arms and legs. And bruising is common in this, so we inspect for bruising, nodules and tenderness. We evaluate for swelling with the Bjork test and check for stemmer sign. So typically the hands and feet are spared, and there's a negative stemmer sign. And then we check for gait disturbance. So classically, we see these cuffs at the wrist and ankles, but they don't have to be present. They are one of the. So lipedema and lymphedema are one of the few diseases that cause cuffs like this. And you can also see like an elbow cuff there where it hangs over the elbow. And then lobules. So here are, this is a lateral thigh lobule or hip lobule, inner knee lobule, and arm lobule. And those are also sort of characteristic of lipedema. So the treatment of lipedema. So it is a systemic disease. It needs to be treated comprehensively. So should not be just treated with surgery. And part of the non-surgical treatment is medical grade compression and a anti-inflammatory diet that emphasizes low processed foods, low and refined carbs. And then other things like compression pumps and things like that can be used. And then lipedema reduction surgery is really the only thing that can reduce the bulk of the tissues that are relatively resistant to diet. But that should be considered only when the conservative measures have not adequately controlled the symptoms. So these conservative measures I just mentioned, including just home exercise, weight loss program, etc., they can reduce the pain and decrease the circumference, but they have not been shown, and I've done studies just using these conservatives, that they've not been shown to reduce the mobility or improve knee mechanics or improve quality of life. Lipedema reduction surgery, which I'm going to focus the rest of the talk on, has been shown to cause those to improve mobility, knee mechanics, and quality of life. So what is lipedema reduction surgery and how? So it's very similar to cosmetic liposuction in that it uses the same instruments, um, um, like the micro air PAL or liposculptor is a key instrument in the treatment. But it's different from cosmetic in that it's focusing on maximal debulking of the subcutaneous adipose tissue. So whereas cosmetic, you want to remove only a limited the optimal amount just to get the best. So you leave some to get the best cosmetic result. Here you're focusing on maximal debulking, and you want to remove not just the adipose tissue but the fibrous nodules that occur in lipedema. And so it is focused on functional gains, not cosmetic results. And then there are special techniques we use, longitudinal cannula strokes, to avoid injury to the principal lymphatics collectors. And I'm going to explain that a little more in the next slide. So because lipedema is known to progress to secondary lymphedema, there's always been a concern about injury to lymphatics with this disease. And so there's early on when this was developed, mostly in Germany, there was a great concern about injuring lymphatic function and flow. And so there was a lot of studies done, and we've now very well mapped these principal lymphatic collectors that are responsible for draining the legs of lymph, and they run along the fascia, just kind of either within the saphenous sheaths or parallel to the saphenous sheaths. And so this is a map of these principal superficial lymphatics that drain the subcutaneous tissue, and as long as these are not injured, we pretty confidently we don't see lymphatic damage. These studies were done. So this is an ICG a direct lymphography. They also did cadaver studies and dissections, lymphoscinograms, and showed that these lymphatic these major collectors are tolerant as long as you do not transect them with crisscross cannula strokes, and they remain intact. However, they can be disrupted by crisscross or techniques. So there's basically 6 parts to the lipedema reduction. So mapping of the principal lymphatic structures. Now that not everybody who's treating lipedema does that. I do and recommend it, but not everybody does. And then marking the area, prepping the patient, doing the tumescent anesthesia, doing the suction aspiration with the longitudinal strokes, and then some fibers of those fibrous lobules are nodules will persist even after the lipedema reduction surgery, the suction part of it, and sometimes those will be removed individually. And then compression is critical in this treatment. We really want to make sure that they're back in their medical grade compression and wear that very consistently after the surgery. So just last year, I published a review of hundreds of patients that we treated with lipedema reduction surgery, and we saw functional improvements in mobility, physical function, quality of life. And this paper was just this summer awarded the best reconstructive surgery paper for plastic and reconstructive surgery in 2023. So I'm very proud of that. So it's the first paper to look at the lipedema reduction surgery in the United States. Most of the studies were done in Europe. Is first to document knee joint improvement, gait improvement, and it correlates patient-reported outcomes with objective physical measurements. Shows improvement in mobility, and uses the same measurements that are used in orthopedic literature to show the mobility and knee flexion, etc. And so I chose the measures that we followed in this study and paper to reflect those that are also followed in a total knee replacement. So we can kind of compare the results of treating the lipedema in the leg versus a total knee replacement. So I know there's a lot with Mike Greer that are familiar with the orthopedic measurements. We check for Q angle and then knee flexion. And you can see here, this is a lady with lipedema, and just the bulk of the lipedema tissue is preventing full knee flexion. So this is a long arm goniometer. We're measuring the knee flexion, and this is where she is, and this is where and then that's the red arrow, and the green arrow, if it comes out on yours, is where she should be. And so there's a marked limitation in her knee flexion just from the lipedema tissue. She has, relatively normal knee joint. And then we also measure the angulation. So there's the excess tissue of lipedema causes mechanical forces that rotate the knee joint, which should be a straight up and down 0 degrees. And this you can see some valgus rotation or valgus deformity in the knee joint caused by the lipedema tissue. So this is the results so the lipedema women had decreased range of motion, knee flexion, normal being around 135, and the average was around 120, and then after surgery it improved to like 128 or 9, and similarly, that's both legs. And then similarly, the angulation or rotation of the knee joint improved from 6 degrees around to around 3 degrees. And those were highly significant improvements. In our study, the Q angle didn't change significantly. As a result of this, the gait of the women in the study showed was 80% had abnormal gait before, and then only 20% had an abnormal gait, or 80% had a normal gait after the surgery. So we showed the data with the improvement in knee flexion. Well, how does that translates into a huge improvement in function? So getting in and out of a car or in and out of a bathtub, you need a full 135 degrees. And so if you're the average patient in that, and you get closer to 130 from your surgery, that's going to make a big impact. And now some women were even significantly reduced below that. So that average was around 120, but there were some in around 105 degrees. And so they would be, just the lipedema tissue would limit their ability to even run or jog or go up and down stairs. Some are even limited to that degree. And so the improvements we see can make huge changes in their ability to do daily activities. So we looked at, PROMISE is a NIH developed toolkit that measures all sorts of patient outcomes. And we specifically looked at the PROMISE mobility um, factors. And a normal would be 50, and these are all, and so our patients had significantly limited mobility um, prior to the surgery, and then after the surgery, it improved highly statistically. The improvements in mobility were about double to triple what we see from a total knee replacement. So more on these patient outcomes. There was a 16% ability to walk at a normal speed, and that's based on these PROMISE measures. Now these improvements correlate with improved life expectancy and decreased risk of developing disability. So they have a huge impact in someone's life. A 16% improvement in ability to go up and down stairs, again correlated with improved life expectancy, and a 27% ability to run a short distance. And you know, again, these are, and finally, 12% improvement in ability to stand for an hour. Now, we also looked at all these domains of quality of life. So there's 8 domains we looked at, from overall physical function, role limitations, energy and fatigue, social functioning and pain, general health. And they all improved significantly prior to after surgery. There was a 12% decrease in overall body pain, a 12% increase in overall health, an 11% ability to handle activities of daily living, and a 13% ability to complete tasks. So I showed you those lobules, and we also, the amount of patients with lobules decreased highly significantly, from about 80% with a thigh lobule prior to, and only a small percent, like 5% had lobules after the surgery. And then that's also knee lobules decreased, and arm lobules decreased highly significantly. So this is an example of lobule before and the lobules gone after surgery. Here's a knee lobule before and a knee lobule after. And you don't have to, be a doctor to see how this lobule can interfere with their mobility. So we stage lipedema there's 3 stages, 1, 2, and 3. And stage 3 is characterized by the presence of lobules. And so getting if prior to surgery they have lobules, and after surgery they don't have lobules, and that could actually be a regression of their stage from stage 3 to stage 2. And this is just like an overall before and after. This is this lady had several lipedema reduction surgeries. She had one on her thighs and one on her hips and buttocks, and on her calf. She had not had it on. She did not have it. I'm going to go back one. She had not. She had her calf done. She had not had her arms done, and so which she may get it in the future. So complications. So the complications are similar to those with liposuction, but there are a few differences. It's a larger volume because we're focusing on maximal debulking. It's a longer and longer surgery. So there is an increased risk of blood clots, or there's increased risk of blood loss in especially those with large varicose veins. And so we do recommend treating varicose veins prior to any large volume surgery. Can also has an increased risk of blood loss. Women with lipedema by themselves, lipedema and lymphedema both have an increased risk of DVT. And then if they are also larger, so many women with lipedema, about 80% are also, their BMI is also increased. So that increases the risk of DVT as well. So those are additive, as well as, so we do recommend prophylactically treating for DVT with blood thinners. And then the great concern about lymphatic impairment, the risk of lymphatic injury. So we published a paper, Dr. Herbst and I, on some lymphatic injury that occurred after liposuction on women with lipedema. And there was this is a 38-year-old woman who with lipedema who developed lymphedema after her surgery on her thighs. This is her lymphocitogram, and you can see for those who aren't familiar, you can see the uptake of the in the lymphatics is normal on one side. That's where the darker line, and then it's markedly diminished in the other leg. Well, thank you so much for your attention. It's really a pleasure to do this and share this with you. I have a video demonstration I'm going to share, and then please feel free. I saved a lot of time for questions, so after the video we can answer questions. So if you yeah, I'm going to move. Hopefully this goes without error. I'm going to move this the video into this screen here. So let me see here. Nope, that's not going to work. There we go. Okay, so I kind of briefly went over the 6 parts of the lipedema reduction surgery. And so again, tumescence is just like cosmetic liposuction is very important. We want to have a very generous tumescence, so because that also has some protection to lymphatic structures. And then I'm gonna. Okay. Well, hold on. Couldn't open. Oh, that's not. I'm going to have to hold on one second here. Have to pull this back up. This may take a second. So while this is this video file is opening, I'm happy to answer questions.
Any questions from anyone?
Yeah, I do. Hi, Dr. Wright. This is Nick Punsel. I'm a project manager here at MicroAir. First of all, thank you for doing this for us. This is awesome seeing how our devices are used to improve your work and improve the lives of your patients. I think that's fantastic. My question is, with cosmetic liposuction, it could take a few hours depending on what the surgeon may be doing. What is the difference in time of the actual surgery for the debulking for lipedema versus a cosmetic procedure?
Yeah, so it is a longer. It's about 4.5 hours is the average surgery time. Now we're very generous with our tumescent. That takes quite a bit of time. And then just the debulking. So it does take quite a bit. It is a bit longer than. I mean, I think an average just cosmetic liposuction is like 2 or 3 hours. This is, you know, at least 50% longer, maybe could be double. So, yeah.
Okay, thank you.
And I want to say something. I really this is a great point. Is why the micro-air pal is really a game changer in this, because I've tried the other so I'm just going to talk over this for a while. And Hi everyone. I want to explain my approach to life. Let me hold on. This guy goes on and on. I'm gonna wait. Here we go. Yeah. Okay. So that's the that's so glad I was able to interrupt him, and you'd have to hear him for like he goes on for almost a half hour. Um, but micro air, you can't debulk the tissue. I mean, I've used the wall or water assisted. I've used, just regular manual tumescent liposuction and Vaser, and none of them I was not able, at least in my hands and others who do this, are not able to get as much of the tissue out with using anything but the micro air pal. I mean, you can get. That's not. I'm not saying can't you can't do a reduction surgery with the other devices. You can, of course, but I don't get as much out. And I feel like I don't get the results that I that I want for my patients without the micro pal. Here, so this is again we do the tumescent. This is so these are larger volumes. So and I wanted to share a little bit of that. So the average lipoaspirate is a little right around 5 liters for one of these surgeries, and it ranges. It all larger ladies will have larger aspirates, and smaller ladies will have smaller, more normal aspirates. But we even on each of the areas, and the largest is doing the inner and anterior thighs. We do stage this and do this in multiple surgeries. There is I feel like there's a limit to how much liposuction should be done in one. That's the dawning of the compression is key to this, because that holds, and that leads to not just skin retraction, but also helps return the lymphatic function. So we really use medical grade compression, and not what is typically done after a cosmetic liposuction. They usually use just sort of Mirena or non-graduated and lower grade compression. So here is me. this is me just,
The saphenous, greater saphenous runs along there. Now, the lymphatics channels that have been well described, and they run parallel to the greater saphenous and the smaller saphenous. And so, so we first, with the high frequency ultrasound, we map the saphenous, and then
so that's just me. This is me just mapping that, which is, and then,
so we have a beautiful lymphatic channel here, Mark, going longitudinally, and my expert sonographer, Kristen,
so this is just, and then this is just marking, what we've marked our lymphatic channels, and then we're marking the areas of our surgery. So this is for a lower leg, ankles and calves. And that's the thing is this affects the whole leg. And so I probably do more ankle and calf liposuction than there's probably very few people in the country or even that do as much ankle and calf liposuction. But that lipedema, obviously that's one of the key areas where it occurs. This is just tumescing, looks pretty much like a cosmetic tumescing. But I do, again, we're kind of keeping parallel in the so you can, we really rely on a very generous tumescent. This is done. So I do this surgery under local plus, oral sedation.
So this is the micro-air lipofilter, and I want to thank micro-air for supporting some of my research. So we use this to help break up the find that we're able to get a little more of the tissue out.
Now that's when I was using the older model. I got the newer models. I just want to be clear. And I
staying clear of them, just going longitudinal of the leg, and nice. Well, right in the plane, the perfect plane for this is the medium plane. It's not too deep, not too superficial, just so smoothly through the subcutaneous tissue.
I'm just trying to. That's just more suctioning, and again, you see the tangential. We do this 360 all the way around, and I'll. So I'm just explaining how we want to get as much tissue out as possible. And so then, they're now, they basically, we rotate them in actually about 6 different positions. So each one, because, so because we want to get, 360 around, but we want to also be going just basically in the arc of just longitudinally. They do have to go into multiple position changes and multiple and so the patient's awake and they're helping me. We move every time we need to go to a different area. We have them move. So each leg gets in basically 6 different positions, and so that's 12 different positions altogether through the surgery. Now they're ending the patient's face down, and so that's basically. Yeah, so that's I just wanted to kind of go over these things, and I'm trying to get my slides down and see if people answer questions. I'd love if anybody have any questions or the. You guys are still
So this
there,
is
right?
Case. Yeah, this is Case Mitchell. I'll ask a question. My title is Program Manager at MicroAir, and I'm interested to know of the areas of the lobules, how much like plastic reconstruction or a skin resection do you have to do, and how much is necessary after you've aspirated the adipose tissue?
Almost no. So about 80 or 90% don't need any additional surgery or skin reduction. They just the all those slides I showed you with the before and after of the reduction of the lobules, they didn't have any additional. It was just the lipedema reduction surgery or the liposuction derivative. That's all they had.
Wow, I think that's both incredible and great. So that's neat to see that it goes back to that level of like natural look, even without any resection of the skin tissue. So that's really amazing.
Yeah. I feel like the compression is so key for that, and but that's yeah, I mean it means a lot because it's again they're going through, if they do their whole legs, that's 3 surgeries, and so we don't want them. I mean that's enough for them. Yeah.
I have another question. Oh, go ahead, Karen.
Okay. I was just going to ask, is this, is it reimbursable?
Yeah. So I would say it's gotten better. So the long story is there was no reimbursement for years. Then there was some reimbursement. Then they had policies, and now they are covering, but not in a reasonable manner. So the average payment, they were they some insurers now are paying as little as $100 for this surgery, or $180. Now some are still paying a reasonable the fair market value, fair and reasonable for the average is like $20,000 for through insurance. But that's again there's a lot. The Anthem is wanting to pay $160, $180 for that surgery, which is just ridiculous. So.
Yeah. Okay. Thank
But
you.
so let me just. So right now we are. In fact, I'm part of the committee that is petitioning the CDC to include the ICD-10 for lipedema. We're trying, the like the paper showing the improvements. I mean, this surgery gives comparable improvements in mobility, in knee mechanics, quality of life, or better than a total knee replacement. So you would think, and again, this is gonna, it would make sense for insurers who, I mean, you don't have to be a doctor to figure out that this tissue is causing extra stresses on the joints. It's gonna, and so it's really foolhardy for them to not cover it, because it's going to lead to worsening health and worsening conditions over time. And but that, again, what makes sense and what gets paid is very different.
Thank you.
But we are having some success. We are having some success and some good coverage. It's kind of, but it's complicated. But I really appreciate the question, because I think it's important. I think hopefully at some point, we will get better coverage.
And Dr. Wright, this is Jerome Barrion. I'm the president for MicroAir. On a somewhat related note, reimbursement might be a hurdle for patients, getting liposuction to treat lipedema. Given what you just showed, also there's technique, right? So how about surgeon training? Or is that something that is quite common and commonly known to do the proper technique for lipedema, or is there also something to be done there from a surgeon training standpoint?
Yeah, there's a great need on the surgeon training standpoint, because there is, I mean, there's very few surgeons that are interested or doing this. And I mean, part of it is, I guess, but so I, was been very lucky, in getting training for this. This is so pretty much everything I showed you was really developed by the German surgeons and Dr. Rapprich and Schmeller and Cornely, and and Sattler as well. And I've spent time with them, and as well as Dr. Klein, who trained me originally in liposuction. And then but I train fellows so the University of South Carolina has venous and lymphatic fellows that come and train here. And we are trying, and then I've trained faculty there. I am in the process of talking to the people. There's a fellowship up at Harvard that I've made some contacts to, but basically training the next generation, because I'm not, first of all, there's much greater need than there is capacity, and then the other part is, this is real. The gray hair is real.
Yeah, no, I mean, clearly this seems like, to your point, just from a patient outcome and then and patient well-being, seems like a no-brainer type of procedure. But yeah, between the reimbursement and the training, my guess is probably not as many patients that could benefit from this are getting this, and so that's by a long shot, I imagine. Yeah.
For sure. It's estimated that up to 11% of women have lipedema, so that's a huge, and we don't. That's the best estimate. It's not a very good estimate, but that's that's a huge need. That's not. And right now, but even getting proper diagnosis. I mean, most women with lipedema don't even know they have lipedema, and they go to doctors who don't know what lipedema is. So there's a lot in there too. So,
Gotcha.
but I do think there needs to be. I'm really trying to. Again, I'm training the fellows and would like to. I feel like this is something that needs to grow, and I really appreciate your support of this. You guys have been great, and I really do appreciate that. And this is really a totally. It is related to cosmetic liposuction, but it is really a totally different, you know, animal, than cosmetic liposuction. And I just, so you can't, and I'm kind of touchy about, this, just someone who just does cosmetic liposuction, just starting to treat lipedema. If they don't treat it properly, you can, yeah, I'm worried that, right, there's a lot to learn, and like the stuff about the compression, the stuff about, I mean, even just management of this there's a lot to it.
Yeah, thank you for saying that. I was hesitant to ask about that, but this could seem like an obvious, um, I was going to say side business, but enhancement of somebody's practice who's purely doing aesthetics. And from what I've seen from your presentation, there's a lot more than just knowing how to do liposuction to do this properly. So,
I mean, it really shouldn't be done by dabblers. You need to really, I mean, I don't think it's certainly a translatable skill set, but,
right.
But it's just, you don't like, I feel like, these are, I mean, I'm going to be honest too. These women often have many other medical issues, and so they're not the easiest patients, and then they really do need, I mean, this stuff, just aftercare and all sorts of stuff that in the diet maintenance and the compression maintenance and stuff like that. That's a totally different mindset from the cosmetic.
Right. Well,
Dr.
thank you
Wright,
very much. Appreciate it.
Yeah, Dr. Wright, it's a great segue to a couple of my questions are related to patient population. I noticed on one of the examples in one of the patients in the video, it looked like she had evidence of like a bilateral knee replacement.
Yeah.
What type of pre-existing conditions do you see coming in from your patient population? And my second question is, what is the age group that you typically see or treat?
Okay. Yeah. First of all, those are great questions. Thank you for those. In my paper, and we looked at, so there's a very high, so normal total knee replacements are like 3 to 5% of the population, as you're aware, but they run about 20% range or even higher in our lipedema patients. And you can see the mechanical stresses of the lipedema tissue means that they're going to have much higher rates of. And then there's also there's maybe other factors, including but that's certainly one. And arthritis is what was, what they put in their history, and knee arthritis are particularly high. Also hip and ankle arthritis. And then repeat your second question.
Age group,
Yeah.
demographics.
Yeah. So we, I mean, we do see younger patients with it, and they're usually earlier stage. It's easier to treat in the early younger patients. But this skews higher than average cosmetic. I mean, I will do patients in their 70s if it's, if I feel like A, they're in good health, and B, it will improve their mobility and stuff. Because unlike cosmetic, the risk benefit, so that we know that it's going to make a health benefit. So we are able to, we can tolerate a little more risk to a risk for a slightly older patient, because it is actually improving their health.
Yep. Thank you.
You have one question in the chat from Trevor. He said the procedure looks physically demanding for you as the doctor. Any thoughts on making the PAL more economic? Or sorry, economic for the doctor. So yeah, since you are doing it for 4 to 5 hours, how does the PAL work for you on that?
Well, I mean, that's why I don't think I could do it without the PAL. But I mean, yeah, I don't know how to make it less physically demanding. If I did, I would definitely be in favor of that.
We'll be working on that for you.
I'm happy to adopt any suggestions that work.
Yeah.
Dr. Wright, I'm Pam Dillon. I'm actually over domestic sales for Microair. And I'm curious because you said it was a number like 11% of women have this condition, and maybe even undiagnosed. But do you see that number trending up over the years, or is it kind of stay around that 10 to 11% of the population that's affected, or is there environmentally something that's causing that condition to grow in numbers? Or
well, that's a great question. Yeah. Well, I think that so that number is based on a clinic estimate, and so it's not a well-studied population estimate, but there's ranges from like 6% to the most recent one in Brazil, they put up to 30% of the population. But that's so I don't know. I don't put a whole lot of stock in that absolute number, but it's large. It is the most common lymphatic disorder affecting women, or affecting anyone in the developed population. And it seems to be trending up, especially with increasing rates of obesity. And so I don't, it's certainly not getting smaller. And it's perhaps, we find that the highly processed diet aggravates this and makes this worse. So it may, so there are people who have, certainly women who have lipedema, who maybe in another generation, when they were more physically active and ate better, even with so there's a genetic cause, and they probably they just maybe had a little bit bigger legs and never really were very symptomatic. But now with our diet and with obesity, they are become symptomatic and more affected by that. So I mean, our diet and our obesity is definitely making this worse.
yeah, and one follow-on question, to actually get an accurate diagnosis, what is the specialty or the physician specialty that you would look for in order to have a good diagnosis?
So this was originally described by venous and lymphatic, and they were at their vascular medicine or venous and lymphatic medicine at the Mayo Clinic. The guy's name was Allen, Edgar Allen, who described that in the 40s, and still this specialty is still the principal diagnoser and recognizer of that. In Europe, it's mostly vascular based dermatologists But that's basically it.
Got
I had one question. I don't know if you can hear me. Let me know. Feel free to repeat. Is that how your patients are coming to you by referral? Is that how the women are finding out
Yeah.
that they even? Okay.
So, yeah. So, I mean, 20 plus years ago when I started treating this, you know, I would see them in my, so in my vein practice, you know, they would present with swelling or in large legs. But now I'm pretty much, it's a national referral. I have even international people coming to my clinic. So it's gone like that.
All right, we're coming up on time, so thank you everyone for your great questions. If you have any more, just go ahead and email them to me and I can pass them on to Dr. Wright and get answers for you or set up a follow-up call and like that. So thank you, Dr. Wright, so much.
Thank you all. And also I want to thanks Karen Keogh, because she's always been there for me. All right.
She's the
Thank you, guys.
greatest.
Yeah.
Thanks, Dr. Wright.
Thank you.
Thank you.
Appreciate it.
Bye-bye.